Thank you, everybody, for joining our CEG QOF webinar on how to maximise your income in 2025-26. So I'm Shazia Shazad. I'm a Senior Primary Care Facilitator for City and Hackney, and today I'm joined by my colleagues.
Hi everyone, my name is Dr. Micah Hanlon. I'm a GP based in City and Hackney, and I'm one of the clinical leads with CEG.
Hello everyone, my name is Toyin Omisori and I am the Primary Care Facilitator for Tower Hamlet.
Thank you. Next slide, please. So what we're planning to cover today. So we'll be, of course, focusing on the changes to QOF 2025-26, and we'll be talking about the retired indicators, the changes to the CBD indicators, and the smaller changes to the other indicators, as well as signposting you to the CEG resources that are there to help you. Just a quick note. Sorry, can you pop yourself on mute, please? Thank you. If you've got any questions or comments, please pop them in the chat. So just a point of note today, usually when we do a QOF webinar, we run through QOF A to Z. However, we do realise that the majority of attendees today are people that are very, very familiar with QOF. So what we've decided to do today is focus on the changes because there are quite big ones this year. And we will be able to support you with any questions that you might have around the other indicators later. But today's webinar will be focusing on changes. Okay, next slide, please. Just a reminder, in case you don't already know, who are we, the Clinical Effectiveness Group? Are any other members of my team on the call? If you can, please pop on your cameras. Just make yourselves known. So we are a team of GPs, analysts, data scientists and facilitators, and we're based at the Queen Mary University of London. So that's a little picture of our building there. We are commissioned by the ICB, and we have access to primary care support, primary care data, across North East London. So what we do is we build dashboards, searches, software tools, and we provide these for GP teams, NHS commissioners and public health. We're a team of facilitators and support officers, and we're there to support you in every practice. We are funded by the NHS and local authorities and research grants, and we do publish research of national and international significance. So that's just a bit about us. On to the next slide, please. So you'll be familiar with this pie chart that we put up in every QOF webinar. So on the left there, you've got QOF last year, 24-25, and you can see it's broken down into three domains. You've got the clinical indicators, which are shown in blue. You've got the public health indicators in grey, and you've got the quality improvement indicators in orange. So last year, 401 points were allocated to the clinical indicators, 160 points to the public health domains, and 74 points to the quality improvement domain. In total, you had 635 points available to you, and each point was worth £220 and 62 pence, of course, asterisk subject to prevalence and practice list size. On the right there now, you can see what's happened this year. So overall, immediately, you can see that more points were allocated to the clinical indicators domain. You've got the complete loss of the quality improvement domain, and you've got a reduced number of points allocated to the public health domain. So you can see there, and I've highlighted it in red just to make it clear to you, the total number of points this year available are much less. You've got 564 points, but the base value has increased slightly to £225 and 49 pence. So I think I should have made that pie chart just a little bit smaller, just to show you there's a bit less in the pot this year. Next slide, please. So where are those points going? So of the 212 points from the retired income protected indicators, 71 points are being removed and invested into the global sum, and 141 points are being redistributed into the 9 CBD prevention indicators. And we'll be talking a lot more in depth about these as we go along. Next slide, please. So just as an overview, 32 income protected indicators have been retired. So 19 of those were register indicators that you can see there on the left. 7 other indicators that are on the right, and you've got the 6 QI indicators. So all of these 212 points were removed this year. Next. And where are those points going? So first I'm going to say, don't worry about trying to read the entirety of this slide and this table. We are going into depth on these indicators, but you can see that this is where the 141 points have been redistributed into these 9 indicators. Next slide, please. So now I'm going to hand over to Dr. O'Hanlon to actually go through the changes to the CBD indicators in depth.
Brilliant, thanks, Shazia. Mevish, do you want to go to the next slide, please? So having a look at these 9 indicators in more detail. So we've got a couple of indicators around cholesterol, and then we've got some indicators around blood pressure management for those on the hypertension register, on the stroke and TIA register, coronary heart disease register, and diabetes registers. What has actually changed about them? So the lower thresholds remain the same, but the upper thresholds are increasing, and quite significantly for some indicators. For all but cholesterol 03, the upper thresholds are going up in some cases by up to 17 percentage points. And the number of points for each indicator is actually increasing as well, and they're going up by around 3 times. Mevish, do you want to go to the next slide, please? So what does that actually mean for practices? Now, because these points were for income protected indicators, you weren't really having to do anything to achieve those points as dependent on previous years. Now, because they are linked with indicators where work has to be done, you have to do a significant amount more work in order to get the same number of points that you had last year, because you were getting those points as part of the income protected indicators in order to hit the upper threshold. So we would recommend, we're going to talk a little bit about how we recommend tackling these, but we recommend starting work early in the year to kind of spread across that burden of work evenly, more evenly over the year. Next slide, please. Putting that into context, so what this actually means financially for practices is quite significant. So we've calculated that for a kind of average practice, so a practice with the average list size in 24 and 25, with the average disease prevalence across years 23 to 24, this would potentially mean an extra 373 patients that you need to meet the upper thresholds compared to 24 and 25 across these indicators. Now, it won't quite be 373 because you will find that some patients will fall into a couple of these indicators if they are on the hypertension register and they're on the coronary heart disease register, for example. So by meeting the blood pressure targets for one, you're meeting it for the other, but potentially is up to around 373. And if this practice were a top achieving practice last year, so they were achieving all the upper thresholds at last year's targets, and this year they achieved the same percentage achievement and didn't increase to the new upper thresholds, they would actually stand to lose around £31,000. So it's a really quite significant impact financially, unless achievements increase to the new upper thresholds. Next slide, please, Mevish. So let's break these indicators down in a little bit more detail to understand what you need to do to get patients to achieve the indicators and the ins and outs of the achievement, but also kind of important exclusions and important ways of removing people from the denominator to try and hit as close or hitting that upper threshold as you can. Next slide, please. So if we look at those 9 indicators, as I mentioned, the first 2 are around cholesterol, and the remaining 7 are around blood pressure control. And if you look at these, they're actually all identical, other than the main comorbidity or kind of cohort is different. So the first 2 are around the hypertension register, the next 2 are around stroke and TIA, the next 2 are around coronary heart disease. And they all have kind of the same targets for the same age ranges. The only exception is with diabetes, with DN36, where they are only looking at patients aged 79 and under. They're not assessing patients 80 plus for the diabetes registers. Next slide, please. So looking at the targets themselves for blood pressure, just as a quick reminder, and how the business rules work with regards to which blood pressures are being assessed for achievement. So they're looking at the latest blood pressure in the year. And if you have a clinic reading and a home or ambulatory reading on the same day, the business rules will only assess the home and ambulatory reading. They'll ignore the clinic reading, but ultimately they will look for whatever the latest is in the year. And what those targets are, so if you're 79 and under, for an ambulatory or home reading, your blood pressure needs to be less than or equal to 135/85, or less than or equal to 140/90 in clinic. For those 80 plus, the diastolic, so the bottom number, remains the same, but the top numbers are 10 higher. So for an ambulatory or home reading, it needs to be less than or equal to 145, and for a clinic reading, less than or equal to 150. Next slide, please. Now, it's important to be, as I mentioned, to be aware of the exceptions from these indicators and thinking about, for those not achieving the indicator, actually, well, what else can you do to try and hit that upper threshold? We'll talk a little bit more detail about some of these key ones, but looking specifically at the blood pressure related CVD indicators, there are codes for being on maximum tolerated antihypertensive therapy. It would be really important just to code that they can't go up any higher, and actually that will remove them from the denominator. There are codes for the quality indicator care being either unsuitable or declined by the patient, and they're subtly different as to whether the patient chooses not to participate in those indicators, or if they are actually unsuitable to be included. And that'll actually remove the patient from all the indicators in the domain. So if they were a kind of quality care indicator for coronary heart disease was unsuitable, all CHD indicators will then be removed from the denominator of those. If the patient declines to have their blood pressure monitored, that will remove them. And then there are codes around invitations, and this spreads across other indicators as well, and they've been aligned to kind of match this rule set. Where if patients are invited to have their blood pressure looked at or their cholesterol looked at on 2 occasions which are at least 7 days apart, they will then be removed from the denominator if they don't have a further kind of blood pressure reading or cholesterol reading. We'll go into that in a little bit more detail about how these can kind of be best and be appropriately used later in the presentation. For these blood pressure CVD indicators as well, any patient whose earliest diagnosis of the kind of entry onto the register is within the last 9 months of the year, or they've registered within the last 9 months of the year, they will not be included in the denominator because you don't really have the time to kind of get that work to optimize things if they're out of control. If they happen to meet the indicator, though, they will be included. Next slide, please. Looking specifically at the cholesterol indicators now, so we're starting with COL03. So what is this about? So this is about patients being on statin or lipid-lowering therapy who have either got established cardiovascular disease, and for QOF that means that they are on the coronary heart disease register, stroke or TIA register, or they have peripheral arterial disease, or those with chronic kidney disease, CKD. Now, to meet the indicator, they either have to be on a statin, or if they're not on a statin, they have to have a reason for not being on the statin coded in their notes, whether that be an intolerance or a kind of persisting contraindication coded ever on the notes, or that they've declined to have a statin or lipid-lowering therapy or an expiring contraindication in year, because those declined decisions, they need to be kind of kept up to date. And they need to be on some other kind of lipid-lowering therapy, whether that be bempedoic acid, ezetimibe, inclisiran, or the PCSK9 inhibitors. Just a note from a change from last year is that icosapent ethyl has been removed from the lipid-lowering therapy list. If we move on to the next slide now, we'll look at the ways a patient can be accepted from this indicator. So if they're on the palliative care register, they're off the indicator. If they are coded as being on kind of maximum tolerated lipid-lowering therapy in year, that will remove them, as well as similarly kind of the adverse reactions ever. If they have not indicated or contraindicated codes to lipid-lowering therapy, now you can either code this with a global code, so lipid-lowering therapy not indicated, or you can do it for each type of medication. Now, obviously, that wouldn't really make sense to do if they're declining all, or if they're not suitable for all. You would just use the global code, you put one code in and it takes them out. And our templates will help you know which code to use. And again, the invites at least 7 days apart. And for this one, the registration date is slightly different because it's just about getting someone onto a medication rather than optimizing onto a certain dose or achieving a certain target. The time range is a little tighter. So if they're registered within the last 3 months of the year, they're out, but before then, they would still be included in the indicator unless they achieve it or they're otherwise accepted. We move on to the next slide, please. Looking now at cholesterol 04, now this is around patients with established cardiovascular disease, so coronary heart disease, stroke, TIA, or peripheral vascular disease. This indicator is not looking at CKD patients, unless they also happen to have CVD. Now, and it's looking at cholesterol targets. So to meet the indicator, patients have to have a cholesterol measurement in year, and that latest test has to either have an LDL cholesterol of less than or equal to 2.0, or if there's not an LDL cholesterol value as part of that lipid measurement, a non-HDL cholesterol of less than or equal to 2.6. The rules are favouring looking at LDL cholesterol. So if you have both, it will only look at LDL. If you don't have LDL, it will then look at the non-HDL. And that's new for this year. Next slide, please. There is kind of some similar kind of exceptions for this one, but an important thing to note for this indicator is that if patients are coded as having a hemorrhagic stroke ever, they are actually not included in the denominator for this. And the way the business rules are written at the moment is this is being looked at before it even checks to see whether they've achieved the indicator. So even if they do have an LDL of under 2, at the moment, if they've had a hemorrhagic stroke ever, they wouldn't actually be included in the denominator at all. Exceptions that you can then add to remove them from the denominator would be maximum tolerated lipid lowering therapy coded in and then similar other codes that we've kind of talked about. So the care quality indicators being unsuitable, declining having their cholesterol checked in the 2 invites, and the earliest CVD diagnosis, or them being registered within the final 9 months of the year. Next slide, please. So how should you actually try and address these 9 indicators? So as we've discussed, trying to start work as early in the year as you can, I think, is going to be important here, because the number of patients you've got to achieve the upper threshold is higher. And being aware of the kind of really important PCAs here is going to be really useful as well. So being aware of maximum tolerated therapy as a code and adding that in, so that if they are on a statin and they're on ezetimibe or they're on other medications and you just can't hit that LDL target and they can't tolerate other medications, use that code and it will show that you're doing the work and you're trying your best, and it will bring them out of the denominator. Decline codes also really important, but it's really important to know which decline codes and which combination decline codes. So trying to use these global codes where you can. So maximum tolerated antihypertensive therapy, maximum tolerated lipid lowering therapy, or declined lipid lowering therapy, declined antihypertensives, as opposed to declined a statin for the cholesterol based indicators. Now, our templates will help you, because we have a PCA section where you will be able to see, we'll show a screenshot of that later on, where it will have all the correct QOF compliant codes, so you can make sure if you're recording that it gets counted and that you're getting paid for the work you've done. Making sure that any expiring codes from last year, if they are still appropriate this year, are re-entered this year, because they are only valid within the QOF year that they're entered into the records in. The expiring ones don't carry on into the next year unless they are re-added. And then we come to kind of making appropriate use of invitation codes. Now, other than cholesterol 3, the count of invitations resets with each. Oh, I think someone's just joined who's unmuted. Do you mind just muting yourself, please? Perfect, thank you. So because the invites reset, it's not inappropriate to look at using these codes early on in the year and thinking about how you use them, how you link them with things like Accurix messages and things like that, but making sure if you're inviting someone to talk about multiple indicators, that actually you code the invite for those domains. Because if you're inviting someone in to have their blood pressure rechecked, well, actually, if they then come and have their blood pressure rechecked again, that counter resets, so you can re-invite them and then chase them up. So it's important to start using those codes for every time you're inviting a patient to come back in to look at their blood pressure, look at their cholesterol. Because if you invite them once and they fail to respond or come in to have things rechecked, and you invite them again 7 days later, well, actually, you're doing the work, you're trying to bring these patients in, and the business rules are really reflecting that you are trying to do that work. And ultimately, if patients then aren't coming back, you shouldn't really be getting penalised for that if you're trying to reach out and trying to bring them in. So make sure you use those codes early on. We've created searches that will be going out soon, and again we'll talk about this a little bit later on, that will help you identify those who need invites and those who need a second invite and are in the correct time period to be re-invited, so you can look at kind of bringing them in. Now, the alerts that the clinical systems produce, they shouldn't remove someone from kind of opportunistic checks of their blood pressure. So if you have invited them twice, they will fall off the denominator for kind of for QOF achievement, but it won't remove them from alerts saying actually this person still needs their blood pressure kind of optimizing or their LDL optimizing, because that's best clinical practice still, even if they haven't kind of responded to the invites. So then you can recheck that. If it's in range, great, they hit the numerator and they're in and helping you achieve your upper threshold. And if they're not, you can start that process of inviting them back in. And ultimately then if they decline, or they decline to have their blood pressure rechecked or cholesterol rechecked, well, that also then removes them from the denominator as well. So it's just important to be aware of these PCAs and make sure you use them so that you hit that upper threshold. They are there in the business rules for a reason, and it is to be used appropriately. Next slide, please. So yes, so this is an overview of our LTC template, and we have a QOF PCAs tab on there with all the correct codes. So these have visibility rules on, so they will only show you the codes for the clinical domain that patient is kind of suitably in. So if they have coronary heart disease, it will show you that. But if they don't have diabetes, it won't show you all the diabetes related codes or sections. And it will give you all the correct PCA codes for QOF so that you can record that and be paid for the work that you're doing. We have a similar tab for QOF invitations as well. That is on some templates, but not currently on all templates. But so if you're not seeing that on your LTC templates at the moment, you should be seeing it very, very shortly. Next slide, please. Brilliant. So I think we'll take a quick pause here now for any questions about kind of what we talked about before we then move on to the next part of the presentation.
Brilliant, thank you, Mike. So I've been monitoring the chat. So Andrew has said, what invite code should we use for cholesterol? So I think that's a really good question, Andrew. Normally, when it comes to invitation codes, I advise that you can type in QOF INV and you will get the bulk of these codes coming up. And they all follow the same syntax. But for cholesterol, it looks like these codes start with lipid monitoring, da 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 da. So the best thing to do is, as Dr. O'Hanlon showed you, have a look on our template. We've got all of the correct invitation codes in there, so you can use those. We've also got a question from Salma saying, does the contract year or the first year start from the 1st of April 25 till 31st of March 26? Yes. Yes, so every contract year will begin on the 1st of April. So actually we are already within it, despite the fact that you don't have the QOF searches available yet. Deepika says, can I please clarify the invitation coding for the BP readings, please? I've noted sometimes I've invited a patient 3 or more times, 7 days apart, and they do not come off the QOF list. Or could this be because they are on another register too soon, such as type 2 diabetes? What do you think, Mike? So
yeah, so I think it depends, and I think what I would emphasize is if you look on the invite section of the LTC template, it will show you all the registers that are included in, so you can make sure that actually if there are blood pressure related indicators, you can make sure you're coding the invites for all of those indicators. Because if you're inviting them, say for the blood pressure looking at hypertension, it won't necessarily flag up that that's being invited for diabetes. So it's just important to make sure that you are using the correct invite codes, and using the template will help you do that quickly and easily, and make sure you're putting the right codes first time and save you doing unnecessary extra work.
Yep, and I'll just add to that. Sometimes the patient has had some activity, so it's really unusual actually that they allow the patient to come in, have the activity done, be out of range, and then you allow you to invite 2 more times and have them come off of your denominator. That's not normal. So if the patient has had some activity and you've coded 2 invitations, they may still sit within your population list. They won't come off that way as a result. But I think it's a case-by-case basis. If you do see something weird like that happening, I would just say contact your local facilitator. We can help you to untangle what's going on there. Kirsty has asked, when will the new QOF reports be updated on EMIS? Good question. Mike, I don't know if you have any sort of insider chat on this, but we are in the same boat as you. We wait until we get that email from Optum, as they are known now, to let us know that QOF searches will be refreshed. So we're not sure. I think historically speaking, it has taken a couple of months to come out. They seem to be coming out earlier year on year. So watch this space.
What tends to happen is so the business rules get released, and at the moment they are provisional business rules, so they are subject to testing. So what we're talking about today is based on these provisional business rules, and that could subtly change in the future. So then EMIS will go about building their kind of iterations of these kind of QOF business rules, but they can't always do it quite like it's written in the business rules. There are sometimes some complexities the way things are coded, or the way the clinical system works. They'll have to try and work their way around. So there can be a little bit of complexity building those, and obviously they want to make sure that they are correct as per the business rules. So it can take a couple of months for those to be released.
Brilliant, thank you. Before I carry on going through the questions in the chat, Zeba, I've noticed you've had your hand up for a little while. Do you want to pop on the mic?
Yeah, I just wanted to ask, is there any indicators that are income protected for this year? Because I did have a look through all the QOF that came out. I know there's new releases now, but they did have quite a few that were income protected, but it in this web session, none were mentioned. So can I just have some highlight on that, please?
The long and short of it is no. So they had the income protection in the last couple of years, and it looked like they were increasing the number of indicators that were protected. But as we said earlier, what's happened is they've done away with a lot of those domains. So a lot of the income protected domains were the register indicators, and you had a few on the side of that. What they've done is they've completely done away with them. They've removed the majority of those points from QOF, reinvested in other areas of the NHS, and they've redistributed the rest of the points into these CBD indicators, which is why we're emphasizing the importance of these, because that's where your income has now shifted to. So sadly, no income protected indicators this year.
Can I ask, you know, you mentioned all the invite codes. Where is that on your template? Because, you know, for the blood pressure, like hypertension and the BP ones, there's no invite code that I can actually find. So where is the template?
Okay, so if you can't find it, as I mentioned earlier, type in QOF INV, which will bring up the majority of the invitation codes. And if the tab is not yet available in your local LTC template, it is coming soon. So Hackney, you will see that that tab is already there, because I think it was drafted at an early stage in there. But we are rolling that out to all of the other boroughs. So if you don't see it immediately, it's coming imminently. Okay.
Thank you so much.
Brilliant. Okay, so Dr. Barron from Spring Hill has said, is there evidence that any evidence that checking fasting lipids will help to meet the LDL less than 2 target? Over to you, Mike.
As far as I'm aware, no. So I personally in practice will do non-fasting frequently. There is no specification within the QOF business rules that they have to be fasting or non-fasting. It may be something you wish to consider if they have done a non-fasting and they are close to or struggling to meet that LDL target, though.
Thank you. I hope that's answered the question. But please let us know if you've got follow-up, Dr. Barron. Jim says, will clicking the pop-up take us straight to the correct template? So we haven't actually referenced any pop-ups yet. The only pop-ups that will be coming up in relation to QOF for now will be created by EMIS. And because they are reliably created by EMIS year on year, we don't tend to replicate those, because then you'll have too many things popping up for you. If we do create something that's QOF specific that we feel like hasn't already been catered to, we will do our best to make sure that it's easy for you to access the template. But at the moment, there isn't an alert that you're clicking on that will take you straight to any QOF pop-ups from us anyway, as CEG. Anise says, what's the invitation code for blood pressure in relation to lipids? I think we've got a bit of a mixed message there, because speaking about the CBD indicators, Mike, you've referenced that the majority of them are blood pressure related, but actually the lipids ones are the cholesterol ones, and those are slightly separate. So as I've said already, you will have those invitation codes on the template available to you either now or imminently. Can we get some help from IT department regarding setting the calling system? I'm not sure how the IT department will support with that, but if you do have any thoughts or any questions, you can contact members of our team. We can guide you through using our resources, and if you've got any ideas on amending it locally for yourself or for any other practices within NEL, let us know and we will work with you to help you with that. But there's no specific support that I know of at the moment, and I'm not sure if any other member of my team knows. And then we've got Pradeep saying, is it more important to keep on top of prevalence now to hit the upper targets? Any thoughts on that, Dwayne or Mike?
So if your prevalence increases, then it will result in you having more money, because what you will get per point is more. So if you can, and also if you are identifying these patients, you can do something about their blood pressure or about their cholesterol. And you are going to be trying to do that work anyway if you are picking these people up. So if you can then record that and count them into your indicator, then yes, that is beneficial.
Brilliant, thank you. And then we have a question from Lisa. If a patient doesn't respond to two invitations more than 7 days apart, and we decline, and then they come in, will their blood pressure be counted? And is it best to decline towards the end of the year or throughout the year? What do you think?
So the way the invite system works for around blood pressure is you invite them once. You've got 7 days to then before you would be eligible to do the second invite. If you do that, they're out. If they then come back and have a blood pressure, that gets reset. So if that blood pressure is normal, within target, they're in the indicator, perfect. If it's above target, then you would be expected to re-invite them in to re-look at their blood pressure. Now, if they decline to have their blood pressure done at any time in year, that will take them out of the indicator. The only exception to that is if their blood pressure later in the year was then to target. They will be back in and they will be included just because of the order that the business rules goes down. So it looks to see about have they actually achieved the indicator first, then it looks through all the exceptions. So if they achieve the indicator, regardless of kind of other codes that have happened earlier in the year, they will be in. But if they have then declined or you've had the 2 invites or so on, yeah, they will then be removed. The invites is dependent on being 2 invitations at least 7 days apart after the latest blood pressure. And similarly with the LDL levels, it's after the latest cholesterol. But declined is looked at any time in year. So that's just an important distinction to make.
Brilliant, thank you, Mike. And that's actually a really good point. The way that the QOF searches are written is they favour patients achieving the target, and then they will work their way through the rest of the rules. So that's in your favour. Okay, so thank you very much. Winston has said, which version of the LTC is currently used? Winston, we have multiple different versions of the LTC template across different localities. There will be locality specific tweaks made, in which case the version numbers will vary. So if you need to know which version is currently in use in your borough, I would suggest getting in contact with your local facilitator. If you don't know who that is, we will signpost you to that person to the contact details at the end. Right. Okay, thank you very much. I don't think there are any more questions, but we do have quite a bit more to go through in this presentation, so I'm going to move us along. Next slide, please. Thank you. So now covering the changes to the other indicators, I'm going to hand over to Toyin.
Thank you, Shazia. Okay, so I'm going to go through some of the other changes that have been made for QOF this year. Next slide. So starting off with asthma. So for asthma reviews this year, the coding for the control test score has been removed from the business rules. And again, for this year, the assessment of inhaler technique has been included in the description of the indicator, but no coding has been included in the business rules so far, although this could change. Either way, it's a good idea and best practice to include this in the review. So for asthma review, what's required is that you need to code the asthma review done code, complete a self-management plan, and this needs to be recorded on the same day as the review. You also need to record the number of exacerbations done in the past year, and this can be done within 1 month leading up to the review. Next slide, please. Moving on to the other asthma indicator. So this is AST012, and it's the recording of the objective test for those who are newly diagnosed. So for this year, it's looking at patients who are diagnosed from the 1st of April 2025, and the objective test must now be done 3 months before to 3 months after the diagnosis. Previously, you could complete an objective test for a newly registered patient within 6 months. However, this seems to have been removed from the business rules for this year. But this is something we can feedback on behalf of practices. The other change is the removal of spirometry as the main objective test. So you may remember that last year you needed to do a spirometry test and another objective test. But for this year, you only need to complete one type of test. So next slide, please. So for this year, you need to complete one of the following. So it's split up by age groups. So for patients aged 5 to 16 years, you can do a pheno test or spirometry with reversibility or peak flow rate variability test, but only if you also code that the spirometry is unavailable. You can do a full blood count and IgE blood test, or you could do a skin prick test for house dust mite and a bronchial challenge test. So those last two are done in hospital. For patients over 16 years old, you can do a full blood count blood test or pheno test or spirometry with reversibility or peak flow rate variability test. Again, you would have to code that spirometry is unavailable, or a bronchial challenge test. NICE has actually done a useful algorithm for which objective tests you can do for each age group, and we've put this link in one of our useful link slides that's further along in the presentation, so that should help you. Next slide. So these are the exception codes that you can use for the asthma indicators. So you can either code that the patient has declined asthma monitoring, or you can record the quality indicators for if the patient is unsuitable or if they decline, and you can record 2 invitations that are at least 7 days apart, and this will also remove them from the denominator. So all of these codes will remove the patient for all of the indicators for the asthma domain. Next slide. So here's just a screenshot of the LTC template page for asthma or the respiratory page. So on here, you'll be able to find all of the payment codes that you need to record for the asthma indicators. Currently, a few of the LTC templates are currently in development, but as soon as we've updated the template, we will let you know. Next slide. So moving on to AS. So there's been a slight change for AS008, which is for prescribing a DOAC, or if the DOAC is declined or unsuitable, a vitamin K antagonist. So for this indicator, they have now included the invitation exception coding for this indicator. So it's now in line with other indicators in QOF. So again, if you record 2 invitation codes at least 7 days apart, it will remove the patient from the eligible population, and this coding will also remove the patient from all indicators for the AF domain. Next slide, please. So as Dr. O'Hanlon mentioned before, each of the LTC templates for all of the localities will have the QOF invitation page, which will list all of the different invitation codes for the different diseases. Next slide. Okay, so moving on to the changes for the diabetes indicators. So for the indicators requiring you to prescribe statin, so that's DM034 and DM035, QOF for this year is now allowing you to code or to prescribe lipid-lowering medication for patients who decline a statin or who are unsuitable for a statin. So next slide, please. So this is just a visual representation of what Dr. O'Hanlon discussed earlier on in the presentation. So this is similar to cholesterol 003. So to satisfy these two indicators, you need to prescribe statin within the last 6 months, or if the patient declines or is unsuitable, so they have an intolerance or they're contraindicated, you need to code that and then prescribe them with a lipid lowering therapy. Next slide. So the exceptions for these two indicators is maximum tolerated lipid lowering therapy. So do code that if you have prescribed a maximum lipid lowering therapy for the patient. So code this and it will remove the patient from the denominator. Record if they have an adverse reaction to lipid lowering therapy ever. Contraindicated or not indicated for lipid lowering therapy in year. If the patient declines lipid lowering therapy in year, or if the patient has an allergy adverse reaction, is contraindicated or not indicated, or declines statin for each of the lipid lowering medications, although it might just be easier to use the global exception code of declining lipid lowering therapy. You can also use the diabetes quality indicator care code for unsuitable or declined to remove the patient, or you can code to invitations at least. Sorry, someone seems to have their mic on. If you could just mute yourself, please. Thank you. Or you can code 2 invitations at least 7 days apart. Next slide. So again, this is just a screenshot of the QOF PCA page on the long-term conditions template. So this will have all of the exception codes for each of the diseases. Next slide. So any questions?
Thank you. Thank you, Tony, for going through that. So I've just noted the time. And what I'm going to do is I'm just going to say, if you've got any more questions, can you please pop them in the chat and we'll come back to them at the end of the main parts of the presentation, because we do have a bit more to go through still. Next slide, please, Mavish. So I'm going to hand back over to Dr. O'Hanlon to talk to the changes through to the childhood immunizations vaccination schedule.
Brilliant, thank you both. So there are going to be some changes to the vaccination schedule for children coming up this year. If we just go to the next slide, please, Mevish. The QOF rules have not changed for the indicators. It's not so much about QOF changes. If we just, so VI 1 to 4 is 1 to 3 for children, and 4 is about shingles for adults. They are unchanged compared to last year. But if we go to the next slide, just to talk a little bit about, actually for practices, what is changing the vaccination schedule? There are a couple of things. So the 12-month kind of Haemophilus influenza B and Men-C vaccine will cease, and it'll be replaced by a dose of hexavalent vaccine given at a new appointment when a child is 18 months old. And that will coincide with the second dose of MMR being shifted from a preschool age appointment, 3 years, 4 months, to this new 18-month appointment. If we just go to the next slide, so I've got a couple of visual representations. Just seeing it all written down, it just gets a little bit mind-boggling, confusing. But actually, if we look at it like this, it becomes a little bit easier to wrap your head around. So on the 1st of July of this year, before that, if children have turned 12 months up to this point, they will get either Menitorix until stocks are gone, or a dose of hexavalent vaccine to replace that. Once we hit the 1st of July, there will be a gap until the 1st of Jan, because children who turn 12 months on or after the 1st of July won't be offered that until they hit 18 months. And the first cohort of that, those who were 12 months on the 1st of July, would turn 18 months from the 1st of January. So this 18-month appointment starts from the 1st of January 2026, and they will get a dose of hexavalent vaccine at that appointment. If we can go to the next slide, please. This will also coincide with a shift in that second dose of MMR. And we can think about there being three main groups here. We can think about this kind of new normal group. So those who turn 18 months on or after the 1st of January 2026, they will just get their second dose of MMR at this 18-month appointment. They are the new normalers. Then we can think about they want everyone to have had their second dose of MMR who is over the age of 18 months by the 31st of October 2026. So for those who are already over 18 months by the 1st of January, by the time this 18-month appointment starts, what do we do for those? We've got the kind of those who would have turned 3 years, 4 months and had their second dose of MMR appointment by that 31st of October cutoff anyway. Well, they just get their vaccine as planned. Nothing changes for those. They have their second dose of MMR at their pre-scheduled appointment. But those who are between 18 months and 2 years and 6 months, well, they wouldn't turn 3 years and 4 months by the 31st of October. It would be after that date. So actually all their appointments are being brought forward to get their second dose of MMR before that 31st of October deadline. And you can think of that as the catch-up group. So you've got the new normal group who are turning 18 months on or after the 1st of Jan. They get it at their 18-month appointment. And then you've got the catch-up group and the as-planned group, because they want all of these to have their second dose of MMR by the 31st of October 2026. Next slide, please. One other change, which is kind of subject to be confirmed, is that they might change the MMR vaccine to MMRV by adding in varicella vaccination from that 18-month appointment inception from 1st of January. But like I say, it's yet to be confirmed. How that would look is, for those who are getting their first dose of MMR or second dose of MMR, is just replaced by this MMRV. Simple as that. For those who have already essentially had their second dose of MMR, so they were 3 years and 4 months or older, up to the age of 6 at its introduction, they just come back for a single catch-up dose of MMRV. And for those who were already 6 to 10 years, if they've not had chickenpox, natural chickenpox infection, or presumably also varicella vaccination, if they haven't had any of those, they would be invited for a single catch-up as well. But if they have had natural chickenpox infection, they wouldn't need to be coming back for a dose of MMRV. Next slide, please. So what resources do we have to help you kind of manage your childhood IMS? Not just around MMRV and this hexavalent 18-month appointment, but just more generally. So for those who haven't seen our APL childhood IMS tool, have a look at it. It's a really useful tool for managing your call and recall of childhood IMS. We got really good feedback about this tool, and I know Rob Moore in our practice really loves using it. So if you aren't signed up for that already, get in touch with your local facilitator and get signed up to use it. Really useful tool. We also have a childhood immunizations template to make sure that what you're coding is kind of standardized and matches all of the QOF rules, and you're using the right codes, because it can be really confusing which ones are which. So the IMS template makes that really easy to use. We have support searches around data quality and making sure that reasons for non-vaccination are coded. And we've also got dashboards to reflect and monitor achievement around vaccinations. And as with all of our indicators and all of our products, we have our wonderful facilitation team to help support you in practices, to answer queries, making sure you know how to use our products. And if you've got patients where you're wondering, I can't work out why this patient's not included in the indicator, can't wrap my head around it, can you help? Just reach out. We are here to help and support you. We're commissioned to support you guys in practice to achieve the best you can. So we are here. Reach out to your local facilitators. At the end of this presentation, we've got a list of who the local facilitators are for different areas with their contact details. So just make sure you know who your local facilitator is and get in touch if you have any questions or issues. Next slide, please.
Thank you, Dr. O'Hanlon. So again, I'm just going to move us on because I can see that we are close to the end of the scheduled time. What we'll do now is we will quickly breeze through the resources that will be up and coming for you, and we will try to answer those questions that are in the chat if we've got time. Apologies if we don't manage to do that, and we will come back to the individuals on those questions. So just a quick slide here showing you useful links. So you hear us present on QOF year in, year out. We give you facts, we give you figures, but actually you might want to read these for yourself. So there is a link to the full QOF 25-26 guidance available there. That will be available in the slides that come out. We've also linked you to the Statement of Financial Entitlements Directions, which is the document that contains the actual monetary figures that are due to practices, so you can read that in your own time. And as Toyin mentioned earlier, we've just linked to the NICE guidance, the flowchart and guidance on objective tests for diagnosing asthma in adults. Sorry, somebody's unmuted. Can you please pop yourself on mute? Thank you. So those will be available to you when these slides come out. Next slide, please, Nevish. Okay, so coming soon. This is everything that we are trying to develop for you to make sure that your year goes a little bit more smoothly. So the overriding ethos here is making sure that you don't have to go too far to find what you need, and that we're trying to condense what we can, again, just to make it easier for you to navigate our templates and work with our resources. So next slide, please. First and foremost, we've got a QOF indicators page coming out for you. So in each and every single one of your review tabs already, you will have a little explanation of what the QOF indicator is and what the requirements are. Well, actually, you might just find it easier to see it all in one page, just in case you've forgotten, so you can come back here. It's within our smart template. So again, it will only display exactly what is relevant to the patient. So if they don't have asthma, it will not show up. So this will be coming to your LTC template soon. Next slide, please. We've got what we're calling the quick QOF template. So again, the idea is that we are making it easier for you to meet the core coding requirements for your QOF indicators. The idea is that you can launch this. It will not have all of the noise or as I term it, the noise, but all of the other information that the main LTC template has. It will only show what's relevant and outstanding for the patient, and it will make it easier for you to ensure that you've met the coding requirements throughout the year, and if you're doing an end of year tidy up, it will support with that. Next slide, please. We've got an administration template coming. So very often practices, more frequently now actually, practices are coming and saying, our receptionists want to help with this contract work. They're doing a lot of recall, they're doing a lot of coding. How can we make it easier for them? So we've heard you, and we are now creating this administration template. Again, it takes away all of the rest of the information on our main LTC template and other templates and makes it a little more user-friendly. And again, as a smart template, it will only show what's relevant to the patient. And basically, it brings together all of the invitation, administrative, repetitive tasks together in one template, so you can easily do it in one go. Next slide, please. As Dr. Hannon mentioned earlier, we will have our search suites coming out to support you firstly with these new CVD indicator changes, and then we will have more QOF support coming out to you. But basically, it will allow you to identify exactly what's going on with your population. Why are they excluded? Are they just missing their blood pressure? In which case somebody can invite them in for a review, or actually do they need some clinical intervention? And we're hoping to make these a lot more usable for clinical staff as well, who will be able to see medication history and other relevant criteria within a quick reference report. Next slide, please. So last but not least, we've got our CVD tool coming out. So it's our CVD prevention tool, slightly different format to our current tools, but the idea is that it will support the optimization of primary and secondary prevention of CVD. It comes out at a time when obviously the QOF has shifted its focus to CVD and prevention. So again, it will help to support those priorities. And if you're a VIP tester, it should be coming out to you soon. Next slide, please. So we are minutes within the end of the presentation. So what we'll do is we will skip this part for now, because you should be familiar with our resources. If you are not, you can always come back and look at the slides, and you'll be able to see those listed for you. Mevish, can you just skip ahead, please, to the contacts page? So if you've got any questions, any queries, you're confused about anything here, or you need some extra support, please get in contact with your local facilitator, and these local contacts are listed here now. This is also available on our website. If you go to qmul.ac.uk/CEG, you'll be able to navigate and find your local facilitator. Thank you all for attending. I've popped a feedback link in the chat. Please, if you can, take 2 minutes to complete that. That is very valuable for us to know that we have hit the right note. We're covering the right things. Is there anything that we can do better next time, or anything that you want to see more of? So please do. I'll pop that back in the chat again, and we will email that out to attendees in case anyone's left at the moment. But thank you for joining us today.